So now we're going to talk about diuretic drugs, and we'll head right into this lecture. In the nephron, wherever sodium goes, water follows. So 60 to 70% of sodium in water is returned to the bloodstream by the proximal tubule. 20 to 25% of all sodium is reabsorbed into the bloodstream in the ascending loop of Henle, and 5 to 10% is reabsorbed in the distal tubules. 3% is reabsorbed in the collecting ducts. So if you look at it, the majority of our water that's in that nephron is going back into the bloodstream. If the water is not absorbed, it's excreted as urine. So here's our first question. Which location is the area where the highest percentage of sodium and water are reabsorbed back into the bloodstream? The glomerulus, the proximal tubule, the ascending loop of Henle, or the distal tubule? Well, all you have to do is look back at your previous notes and you'll see that the proximal convoluted or twisted tubule, or more simply the proximal tubule, anatomically follows the glomerulus and returns 60 to 70% of the sodium and water from the filtered fluid back into the bloodstream. Another 20 and 25% of sodium is reabsorbed into the bloodstream in the ascending loop of Henle, and the remaining 5 to 10% of sodium resorption takes place in the distal convoluted tubule, often called simply the distal tubule, which anatomically follows the ascending loop of Henle. The glomerulus does not resorb sodium or water, but instead is the point where the initial filtration of the blood happens. There's several different types of diuretic drugs, and we'll talk about each one of them. Carbonic anhydrase inhibitors, example would be acetazolamide or Diamox. It's one of the most commonly used carbonic anhydrase inhibitors. The mechanism of action for them is that the enzyme carbonic anhydrase helps to make the hydrogen ions available for exchange with sodium and water in the proximal tubules. The carbonic anhydrase inhibitors block the action of the carbonic anhydrase, thus preventing the exchange of hydrogen ions with the sodium in the water. Further, the inhibition of the carbonic anhydrase reduces hydrogen ion concentration in the renal tubules. So as a result, there's an increased excretion of bicarbonate, sodium, water, and potassium. The resorption of water is decreased and the urine volume is increased. So another way of thinking about this is that with more bicarbonate always has to have something to go with it. It doesn't just go off by itself. So it normally goes out as either sodium bicarbonate or potassium bicarbonate. Well, with sodium or with potassium, water has to follow. So if you're excreting more sodium bicarbonate or potassium bicarbonate, you as a result are going to be excreting more water as a result. The indication for carbonic anhydrase inhibitors include adjunct drugs in the long-term management of open-angle glaucoma, use with miotics to lower intraocular pressure before ocular surgery in some cases, and it's also useful in the treatment of edema and high-altitude sickness. The contraindications for carbonic anhydrase inhibitors include, of course, the known drug allergies. If somebody is suffering from hyponatremia or hypokalemia, think about the fact that it's making you excrete more of these ions. Also, severe renal or hepatic dysfunction, adrenal gland insufficiency, or if the person has cirrhosis of the liver. The adverse effects associated with them include acidosis. Well, if you are excreting more bicarbonate, that means that you're not retaining it, so you don't have a base to balance off the acids, so that makes perfect sense. Hypokalemia comes because we're peeing out more potassium. Drowsiness, anorexia, paresthesias are associated with hypokalemia and acidosis. Hematuria, urticaria, photosensitivity, and melena, which is blood in the stool. As far as their interactions with other drugs, because the CAIs can cause hypokalemia, an increased risk of digtoxicity may occur when they're combined with digoxin. Also, use with corticosteroids may cause hypokalemia even more than what would happen with the drug by themselves. There's increased effects of amphetamines, carbamazepine, cyclosporin, phenytoin, and quinidine when used with the CAIs. I want to go back to the corticosteroid comment there because corticosteroids themselves can cause hypokalemia. So when you combine two drugs that can cause hypokalemia, you definitely increase the risk of that happening. Loop diuretics are called that because they act on the loop of Henle. They include bumetanide, ethanocrinic acid, furosemide, and torsemide. The mechanism of action for loop diuretics is they possess renal, cardiovascular, and metabolic effects. They act directly on the ascending limb of the loop of Henle to inhibit chloride and sodium resorption. So they keep sodium chloride from being reabsorbed. This increases the renal prostaglandins and results in the dilation of blood vessels and reduced peripheral vascular resistance. It's also useful in the treatment of edema. The loop diuretic's drug effects is that it's a potent diuretic, and so you definitely lose fluid after. Think about Lasix, furosemide. We give that, and usually within minutes of when we give it, especially if we give it IV, that person is getting up and going to the bathroom. It also can decrease fluid volume and causes a reduction in blood pressure, pulmonary vascular resistance, systemic vascular resistance, central venous pressure, and left ventricular end diastolic pressure. This is all because of the decreased fluid volume that it causes. It can also cause potassium and sodium depletion, so we have to think about monitoring electrolytes when somebody is receiving loop diuretics. The indication for loop diuretics include edema associated with heart failure or hepatic or renal disease. It's also used to control hypertension and to increase the renal excretion of calcium in patients who have hypercalcemia. In cases of heart failure resulting from diastolic dysfunction, it can improve the diastolic function by decreasing the preload, preload. There's two slides here that look at the adverse effects of loop diuretics, and they go by body systems as far as what kind of reactions they have. I'll let you read through those, and I'll catch up with you in a couple slides. The interaction with other drugs with loop diuretics has a lot to do with the fact that loop diuretics can be neurotoxic and they can be nephrotoxic. And when other drugs have the same kind of action on it, on the kidney, it can make things even worse. So what we see with perhaps gentamicin, which is nephrotoxic, if they're on loop diuretics at the same time, it can cause a severe nephrotoxicity. Increased serum levels of uric acid, glucose, alanine aminotransferase, and aspartate aminotransferase can happen. And with thiazide, you can get a sequential nephron blockade if it's given with it. It also has interactions with the nonsteroidal anti-inflammatory drugs because they also have kidney reactions with them that can lead to nephrotoxicity. Furosemide, or Lasix, is the most commonly used loop diuretic. It's used for pulmonary edema and the edema associated with heart failure, liver disease, nephrotic syndrome, ascites, and hypertension. When administering a loop diuretic to a patient, it is most important for the nurse to determine if the patient is also taking which drug: lithium, acetaminophen, penicillin, or theophylline. So the answer to this one is A. Use of loop diuretics with lithium can increase the risk of lithium toxicity. Drug interactions with loop diuretic therapy can occur with concurrent use of nonsteroidal anti-inflammatory drugs. And vancomycin can cause increased neuro and ototoxicity when used with loop diuretics. There is no associated risk of drug interaction when the patient is taking acetaminophen, penicillin, or theophylline with loop diuretics. Osmotic diuretics include mannitol, which is the most commonly used osmotic diuretic, urea, organic acids, and glucose. The mechanism of action for osmotic diuretics is that they work mostly in the proximal tubule. They're non-absorbable, and so they produce an osmotic effect, meaning that they pull water into the renal tubules from the surrounding tissues, and they inhibit the tubular resorption of water and solutes, and so they produce a rapid diuresis. And it's amazing to watch this happen because when you give this to a patient, they can be sitting there just as puffy as you've ever seen in your whole life. And you give it to them and they start putting out urine, and before you know it, they don't look puffy at all. It's really, it has such a fast reaction. These drugs affect the body by increasing glomerular filtration rate and renal plasma flow, and it helps to prevent kidney damage during acute renal failure. It also reduces intracranial pressure or cerebral edema associated with head trauma, and this is one of the major uses of these osmotic diuretics. It also reduces excessive intraocular pressure. So the indication for using these osmotic diuretics are treatment of patients in the early oliguric phase of acute renal failure. The oliguric phase, like it says, is that they are not putting out any urine. It's also to promote the excretion of toxic substances, to reduce intracranial pressure, and as a treatment for cerebral edema. Some of the adverse effects that can happen with osmotic diuretics include convulsions. As we know, if you change fluid volumes too quickly, the brain doesn't like that. And so the use after head trauma has to be very gentle. It can also cause thrombophlebitis and pulmonary congestion. Mannitol or osmiditrol, I've never seen it with a name. I've always seen it just called mannitol, is given by IV infusion only. It can crystallize if it's exposed to low temperatures, so this is definitely not something you're sticking in the refrigerator. And you need to use a filter when you're using it. While preparing an infusion of mannitol, the nurse notices small crystals in the IV tubing. The most appropriate action by the nurse is to A. Administer the infusion slowly, B. Discard the solution and obtain another bag of medication, C. Obtain a filter and then infuse the solution, or D. Return the fluid to the IV bag and dissolve the crystals. Well, this is one of those kind of obvious ones, and we're going to B. Discard the solution and obtain another bag. Even though a filter should always be used with this medication infusion, a solution with crystals present in the bag or the tubing should never be infused. The nurse should first discard the solution and then restart the infusion with a new bag, ensuring that there is a filter on the IV bag in the IV line in case crystals should develop. Potassium-sparing diuretics include amiloride, spirolactolone, triamterene, and these are also known as aldosterone-inhibiting diuretics. The mechanism of action for potassium-sparing diuretics is that they work in the collecting ducts and the distal convoluting tubules, and they interfere with the sodium-potassium exchange. They competitively bind to the aldosterone receptors and block the resorption of sodium and water, usually induced by aldosterone. So the drug affects the body by preventing potassium from being pumped into the tubule, and that prevents its secretion. It competitively blocks aldosterone receptors and inhibits their action, and that promotes the excretion of sodium and water. So as you can guess, the two things that we have to watch for with this drug is that we have high levels of potassium and low levels of sodium or hyponatremia. So let's look at the various indications for these drugs. Spirolactone and trimeterene are often given for hyperaldosteronism, hypertension, reversing potassium loss caused by potassium-losing drugs like loop diuretics, and in certain cases of heart failure for the prevention of remodeling. Amiloride is similar to bractolone and trimethorone, but amiloride is less effective in the long term. Like before, I'll let you read through these various adverse effects in these two slides and catch up with you on the next one. Potassium-sparing diuretics have interactions with lithium, with angiotensin-converting enzyme inhibitors or ACE inhibitors, potassium supplements, because again, if I'm not peeing out my potassium and I'm retaining that potassium, I'm probably not going to need potassium supplements. And there's also a interaction with NSAIDs. Moving on to thiazide and thiazide-like diuretics, the thiazide diuretics are hydrochlorothiazide and chlorothiazide. So we have esadrux and hydrodiuryl, and then we have diuryl. The thiazide-like diuretics are metalazone, chlorothiazidone, and inadaptamide. The mechanism of action for the thiazides and thiazide-like diuretics is that they inhibit the tubular resorption of sodium, chloride, and potassium ions. And so the action primarily takes place in the distal convoluted tubule. As a result, water, sodium, and chloride are excreted, and potassium is also excreted, but not as much as the sodium is. It also can dilate the arterioles by direct relaxation. The drug effects of thiazides and thiazide-like diuretics include lower peripheral vascular resistance. Think about the fact that they relax the arterioles. That's how they do this. It also can cause a depletion of sodium in water and to some degree potassium. Thiazides should not be used if the creatinine clearance is less than 30 to 50 milliliters per minute. Normal is about 125 milliliters per minute. Metalazone remains effective to a creatinine clearance of 10 milliliters per minute, but most people don't want to risk it when you have such low creatinine clearance. The indications for these drugs include hypertension. It is one of the most prescribed drugs for this, and it's usually used in combination with whatever antihypertensive drug they're on. And in fact, usually what we see is a combination drug where it's their ACE inhibitor or their ARB with a thiazide or a thiazide-like drug mixed in with it, so they just take one pill. It's also used for edematous states, idiopathic hypercalciuria, diabetes insipidus, heart failure caused by diastolic dysfunctions, and as adjunct drugs in the treatment of edema related to heart failure, hepatic cirrhosis, or corticosteroid or estrogen therapy. And now we're ready for the nursing implications. We definitely are going to perform a thorough patient history and physical exam. We're going to assess baseline fluid volume status, I&O, serum electrolyte values, weight, and vital signs, especially postural blood pressure. And I really want to emphasize the serum electrolyte values. If you don't know where this person's sodium and potassium is before you start diuretics, how are you going to know if you've had a great decrease in them or if they're just it's normal for them? You want to assess for disorders that may contraindicate or necessitate cautious use of these drugs. And you want to instruct patients to take the medication in the morning if possible to avoid interference with sleep patterns. Again, these drugs make you have to go to the bathroom. So if you take them just before you go to bed, you're going to be up all night going to the bathroom. So they need to take them in the morning when they're awake and it's not going to mess up their sleep. While on therapy, we need to monitor the serum potassium levels as well as the sodium levels. We want to teach patients to maintain proper nutritional and fluid volume status. So often these patients need to have watch how much fluid they're taking in because they can. It's usually one of the causes of their edema is their heart function. We want to teach patients to eat more potassium-rich foods when taking any but the potassium-sparing drugs because all of them cause potassium to be lost, but the potassium-sparing ones, if they eat too many potassium foods, then they're going to get a high level of potassium. So foods that are high in potassium include bananas, oranges, dates, apricots, raisins, broccoli, green beans, potatoes, meats, fish, and legumes. Patients taking diuretics along with digitalis preparations should be taught to monitor for digitalis toxicity. Patients with diabetes who are taking thiazide or loop diuretics should be told to monitor their blood glucose and watch for elevated levels. You want to teach the patients to change their position slowly and to rise slowly after sitting or lying to prevent dizziness and fainting related to orthostatic hypotension. You want to encourage them to keep a log of their daily weights. And remember, that's how we monitor fluids, whether fluid loss or fluid gain in patients, is daily weights. Remind patients to return for their follow-up visits and their lab work. Patients that have been ill with nausea and vomiting and diarrhea will have lost additional fluids. So when you combine that with the diuretic effect, it's going to lead to fluid and electrolyte imbalances. Signs and symptoms of hypokalemia include muscle weakness, constipation, irregular pulse rate, and overall feelings of lethargy. Make sure that the patients are instructed to look for these signs and symptoms. You want to instruct patients to notify their primary care providers immediately if they experience rapid heart rates or syncope, which reflects their hypotension and their fluid loss. You also want to be aware that excessive consumption of licorice can lead to an added hypokalemia in patients that are taking thiazides. You also want to monitor for adverse effects, and the adverse effects are going to include things like metabolic alkalosis, drowsiness, lethargy, hypokalemia, tachycardia, hypotension, leg cramps, restlessness, and decreased mental alertness. And in fact, things like leg cramps and the restlessness will come much earlier than some of the other signs, and that will be a indicator to you that the potassium levels are starting to get low. You also wanted to monitor for hyperkalemia with potassium sparing diuretics. You're going to monitor for the therapeutic effects that include reduction of edema, reduction of fluid volume overload, an improvement in their heart failure symptoms, a reduction of hypertension, and a return to normal intraocular pressures.